All right, we are live.
Wonderful.
So I always have to check what's happening. And I got the confirmation. Dr. Irgau, how are you doing?
I'm doing good. I'm doing good. Sorry about the delay, Kemal, and thank you for your patience.
That's all right. It's part of our reality, right? So we are real people in medicine, and you're a real surgeon. So when you are operating in the hospital, this is what happens. So today, Dr. Irgau was. He had a couple of cases, and then second one or the third one did have some delays outside of our control. Yep. Anyway, welcome back. Today is July 16th. This is our Bariatric Friday. We finished 2 rounds of our events, and this is the 3rd round of our Bariatric Fridays. So we are going to go back to type of bariatric procedures. Every time we do these, we pick up new stuff. Even for us, sometimes we were able to make some changes, but just to kind of make some introduction. So then, in case you haven't watched any of the videos that we have done before, my name is Kemal Erkan. I'm the chairman of American Surgery Center as well as United Medical ACO. And I have Dr. Isaias Irgau with me. Dr. Irgau.
Thank you, Kemal. Hello, everybody. Welcome again to Bariatric Friday. My name is Dr. Irgau. I am a bariatric surgeon. I am the president and co-founder of CHRIAS, Christiana Institute of Advanced Surgery. My specialty is weight loss surgery or bariatric surgery, and I have been performing weight loss surgery now for about 20 years. So thank you.
Thank you, Dr. Irgau. So just so that in case, again, if our audience, if you haven't seen the other videos, so other than Dr. Irgau, we have Dr. Gail Wynn, Dr. Mike Peters, Dr. Rahul Singh, Dr. George Ibrahim on the bariatric side, and Dr. Sachin Wade as a colorectal surgeon who's completing our team from the surgical specialty side. And then our dietitians, Fran, Amy, and Beth, their specialty is on the bariatric as well as the diabetes, but most of their time is spent between the diabetes and the bariatric. So our team did more than 10,000 surgeries, bariatric surgeries among the 6 surgeons. In the last 3 years, that's about 2,000. Now, we could have done maybe more surgeries in the last 2 years, but our focus is shifted to our surgery center. And we had several different reasons for this. And that's because we wanted to focus on individuals who can actually experience the bariatric surgery from the beginning of this initial journey, because bariatric is not something that you can actually just decide and then 2 weeks later you can get your surgery. Just like if you have a gallbladder problem, you can, but if for the bariatric, the process starts much earlier. And because of that, we made these videos available for our patients early on. So these are some of the videos that you can actually watch them. Now, from the qualification standpoint, again, this is kind of sad to use the word qualification for the surgery that is curing the chronic issue, right? So when we talk about chronic care issues, and then you have to qualify to get a surgery to fix the problem. So it's just like, when I sometimes put these sentences together, I'm like, what am I saying? Why am I saying it this way? Well, because this is what the insurance company wants me to say, or this is the institution wants me to say. So, it's a qualification. So you have to be 18 and older. Well, this is understandable. You have to be 100 pounds overweight. So if you are 88 pounds overweight, that means you have to gain weight. So that doesn't make sense, right? So but that's what it is. So your BMI needs to be over 40. And if it's between 35 and 40, you have to have one of the comorbidities, which is one of the illnesses, such as high blood pressure, diabetes, heart disease, or sleep apnea, which many of these do come with obesity anyway. So now today, Dr. Irgau, we want to go back to the bariatric surgery options. So this is one of the questions that always comes up, and we give the answers all the time, but sometimes the ranking of these surgeries do change. So if you can actually elaborate these, and I'm going to share this through the PowerPoint. So, and then there's individual slides for each of them.
Absolutely. Yeah, thank you, Kemal. Thank you. I mean, with your introduction, you clearly outlined bariatric surgery is a treatment for a chronic disease, which is severe disease, which very often is actually the center of many other correlated diseases as well, as you briefly mentioned, whether it's high blood pressure, cardiovascular disease, whether it's diabetes, whether it's sleep apnea, whether it's problems with one's joints, whether it's problems of constant headaches, whether it's heartburn, whether it's asthma, whether it's enlarged liver. All these diseases are actually very clearly correlated with morbid obesity, and rather than treat each one of those illnesses separately forever, it is much more effective and important for the patient to treat morbid obesity. And currently there is no other treatment that is as effective as bariatric surgery when it comes to treating morbid obesity. And bariatric surgery essentially is a treatment that entails some intervention by the surgeon on the digestive tract to bring about changes that will stimulate the body to allow the person to lose weight significantly. That very, very difficult goal of weight loss that many people have tried over and over again, and they've find themselves in the same situation or even at higher weight over and over with different diets, with different programs. With weight loss surgery, there is real tangible weight loss after bariatric surgery. So what kind of interventionists we do? Well, we can do a number of procedures. All of them entail some type of change on the digestive tract. There are procedures that are that utilize some type of device. For instance, these tend to be the less invasive procedures, but also the results from these procedures tends to be less drastic when it comes to weight loss. For instance, you have the lap band surgery on the top left-hand corner, Kemal, that entails placing a device in the upper portion of the stomach to interfere with the person's ability to eat large amounts of food. We used to do the lap band, but we don't do as much now. In fact, we find ourselves really taking out many bands because of problems and complications. However, it's still an option, particularly for people who are looking to achieve modest weight loss. The appeal with the lap band, of course, is that it is a device and it can be removed. And from that perspective, it can be categorized as a reversible procedure. On the bottom right corner, you have another device procedure, Kemal, which is the gastric balloon. This is actually a totally endoscopic procedure whereby without making any incisions on the skin and just going through the mouth, we can utilize a camera to insert an actual balloon inside the stomach that will make the person feel full once the balloon is in the stomach. This is, again, a very non-invasive procedure, but it has limited scope in terms of how much weight a person could lose. We're talking about anywhere between 25 to 40 pounds weight loss on average with this procedure. And it's a procedure that has a finite timeline. In other words, the balloon cannot be in the stomach indefinitely. It has to be removed because the balloon itself has a lifetime limitation, but also it can interfere with the health of the stomach if it's left beyond the 6 months time period. So those are the device-based procedures, the less invasive procedures. And then we go to the procedures where we really impact some important changes on the digestive tract, but Similarly, we have very significant weight loss as well. So let's start with the one on the top center, which is the sleeve gastrectomy. That's the sleeve gastrectomy. Now, I would like to clarify one thing, Kemal, that comes up often and often, right? And people think that when they hear sleeve gastrectomy, they actually think about a sleeve-shaped device that is placed to envelop the stomach. They think that that's what we're doing. And so I find patients coming to me and say, hey, doctor, can you give me the sleeve? Can you put a sleeve in me? Thinking that it's a device. Well, actually, that's a misnomer. It's not a device. The sleeve actually describes an actual procedure whereby we're actually cutting the stomach in a certain way, and we make the stomach a lot smaller than its current size.
You were also making that, Dr. I remember, with the sleeve, I thought you were cutting it and then just making a sleeve for a long time until
That's
I
right.
like, oh, okay, that's not the case. So
that's right. So in a way, it's a confusing name. It just tells you that surgeons don't have much imagination when they name their operations, right? They call it the sleeve because the remaining stomach looks like a shirt sleeve. It's tubular. It looks like a banana, but it's not a device. It's a procedure whereby we actually
don't name these. So we should have fashion designers should.
That is true. That is true. Maybe we should put it out there before naming a new operation. We should have people compete for finding a name. So going back to the sleeve, as you can see, the before and after, you can see that the stomach has now been divided. There is a much smaller stomach. This actually happens to be by far the most common and really popular procedure that we perform by far. It is very effective. The weight loss is excellent. And also the long-term implications of this procedure are not as drastic as other procedures where we have to do some kind of bypass of the intestine. That's why it's really so popular very often. So exactly. So it is a procedure that in our center, the American Surgery Center, is actually performed more commonly as well. And it's an outpatient procedure where people have their surgery and go home the same day. But it is still bariatric surgery, which means that the actual preparation for the surgery has to be rigorous in terms of selecting an appropriate candidate, but also preparing the patient for success by having them interact with our multidisciplinary team, including our dietitians, psychologists, and other physicians as well. And all that preparation is, of course, coordinated by our wonderful care coordination team that meets every day to follow the progress of our patients. The sleeve gastrectomy, although we are removing a big portion of the stomach, it's still incisions, very small incisions, about 4 or 5 of them. And we are able to squeeze out that big portion of the stomach through one of those incisions as well. The next procedure we're going to discuss is the gastric bypass. That is
before we go to the next, on the sleeve,
yes.
From the part that we remove on the stomach, is there any part of the stomach that's different than the other side? Like the part that is removed, is there anything that's different than the other side that's remaining?
Absolutely. That's actually a key question, Kemal. That's absolutely right. So the reason we cut the stomach specifically on that portion and remove that portion of the stomach is very important, because the portion of the stomach that we remove, first of all, is the most stretching portion of the stomach. It is that part of the stomach that really accommodates food without increasing the pressure on the stomach. So we don't feel the pressure even by eating a lot of food. So it's very accommodating. It's almost like a balloon. It kind of stretches and stretches as the stomach is filled. So that is one. And the second point is that many of the cells that actively participate in communicating with our brain to tell our brain when we're full and we're not, where we're hungry, actually reside in that portion of the stomach. And by removing those cells, that portion of the stomach, actually, we remove the influence of the cells on our brain, and we become less hungry, and we are less likely to search for food frequently. So very, very important, actually, to remember that. And then the portion of the stomach that is left is a lot stiffer. It doesn't quite accommodate quite as easily the food.
I just want to kind of repeat that in a maybe different way. So on that part of the stomach, this gut connection to the brain the only way that our brain knows that we are hungry is because of the communication that we get with the cells. So that those cells are on that side of the stomach, and we are removing that.
Yes.
And then that's not only making the stomach smaller, but also the communication is also cut off.
Absolutely.
Right?
Absolutely.
So, because that's many people, they understand it as like, oh, it's just like cutting the stomach, but that's not the case.
Absolutely. We are actually impacting very important metabolic changes, right? Our metabolism is the process that determines our energy balance. So our metabolism is fundamental in how much food we seek out, right? And how much energy we consume, right? That is an extremely complex process, but the digestive system and the brain actually play pivotal role in that. And by doing this surgery, we actually impact that metabolism in a beneficial way. That is why, Kemal, very interestingly, regardless of how much weight the person is losing, we see so much improvement, for instance, in the control of blood sugar after this surgery, right? Patients who are diabetic are much better in controlling their blood sugar, sometimes even getting off their medications after these procedures. Similarly, patients who suffer from high cholesterol, from high blood pressure, because the metabolism is impacted in a beneficial way, we see great improvement. In fact, because really we are impacting metabolism so much, Kemal, our society, the one that you and I participate, the American Society of Bariatric Surgeons, actually a number of years ago changed its name to now being called the American Society of Metabolic and Bariatric Surgeons. That's why we are called ASMBS now. So this is to show that we're not really changing the digestive system to make the stomach smaller so that the person eats less, which is true also, but that's a very simplistic way to look at the results of bariatric surgery. It's much more impactful from that point of view.
Absolutely. So the next procedure is bypass.
The gastric bypass. The gastric bypass really is the procedure that bariatric surgeons actually refined very, very earlier on when bariatric surgery was really at its inception. And with with gastric bypass, actually the changes are far more drastic compared to the sleeve gastrectomy. As you can see in the before picture, you have the food pipe, you have the stomach and the intestine. In the after picture, you can see that the stomach has been divided now really high up so that there is a very small portion of stomach that we call pouch that is still connected to the food pipe, but the rest of the stomach, the larger portion of the stomach, is totally disconnected from that food pipe area. Right there, absolutely. Now, we have disconnected the stomach. We have to find an outlet to that little stomach. The food that comes from the food pipe and enters in the little stomach now has to find its way to the intestine because that way has been interrupted when we cut the stomach. Well, we re-establish the continuity by actually cutting the intestine below and bringing up one portion of the intestine and connecting it with this little stomach to create what's called a bypass. That's why it's called a bypass. We're bypassing a large portion of the stomach and that early portion of the intestine. So this procedure has implications because not only now we're making the stomach that receives the food far smaller, but we are rerouting the food way away from that early portion of the intestine, which happens to be one of the most active portions of the intestine when it comes to absorbing nutrients and absorbing calories. So it's a very impactful procedure in terms of the weight loss and in terms of the impact on the metabolism of the person. But also because now we have really drastically changed the route of the food around the intestine, there are implications long-term in terms of vitamin deficiency, in terms of potential for the intestine to twist and things like that. What we have found in our studies is actually the weight loss difference between the gastric bypass and the gastric sleeve is not as great as it is to be thought of. So to just seek the gastric bypass because one wants more weight loss compared to the gastric sleeve does not seem to be that important. There are, however, situations where we say the gastric bypass is a better procedure compared to the sleeve and vice versa. Now, which procedure ultimately will be better for a patient, Kemal, as you and I talk very often, is best determined during the consultation. And the consultation is where the interaction between the bariatric patient and the surgeon occurs when you session like this one, and we have other seminars as well, as Kemal mentions. But then you have to come as an individual for your consultation, where it's going to be just you, the surgeon, or just you and the surgeon and members of your family, if you wish to bring them. And what we do then is, the first part of the consultation really is to uncover your medical history. We look at the past history, we look at the struggle with weight, and we look at things that have been done in the past. And then together we can decide as to what is the best option at that time. And very often patients may not be totally certain as to which procedure they may want, even after the consultation. But then the idea matures through their interaction with our multidisciplinary team, as the bariatric coordinating team takes them through the various specialists, and they learn more. Then which procedure might be better for them obviously matures in their head over time.
I think Dr. One of the issues that I see as I mentioned earlier, other than my responsibilities from the surgery center, I have accountable care organization, and we do the population health management. And right after our bariatric case conference, I have the accountable care organization case conferences. And the treatment for the obesity is lacking. It's lacking from primary care level. It's lacking from the patients. I think the way that patient maybe their understanding what obesity does, it's more like the look versus this is a chronic illness. So what type of surgery is not the first or the most important question. The question is like understanding this issue first, and then understanding and accepting the problem first. So then because there's enough time to decide which procedure you are going to go to, because regardless of which one it is, if you have one of the Medicaid products, there's 6 months of the nutrition. And during that 6 months, we can decide together which procedure would be the right one. But you don't have to decide which one it's going to be in the beginning, right? So
Absolutely. I mean, that's a great point, Kemal. You see, even among bariatric surgeons, very often we spend too much time discussing which procedure is going to give an extra 20-pound weight loss, or is going to resolve this comorbidity earlier. Well, we have effective procedures. Yeah. We have very good procedures, right? That do the great part of the job that they're required to do, which is to help people lose weight effectively. Our problem is not necessarily having the more perfect procedure. Our problem really is convincing the vast majority of patients who struggle year after year, decade after decade with the weight that continues to pile up, right? And I have a 45-year-old patient who comes to see me, Kemal, with a body mass index of 50, which is having 120, 150 extra pounds in their body. And I talk to them and I say, look, how will you be able to carry this and more extra weight in 10 years' time, in 15 years' time, in 20 years' time? It's going to be virtually impossible. And the patients know it. They say, look, this weight is going to kill me. I know it, doctor. So they understand. So our challenge really is to continue doing sessions like the one you're doing, Kemal, to convince people that there is an effective treatment with obesity. There is no reason for them to suffer year after year with the weight and with the diseases related to weight. We do have excellent procedures that can take care of this. And we have refined bariatric surgery now to the extent with programs like the ones we have at the American Surgery Center. The safety level is so high, Kemal, so high. There is actually virtually no surgery that goes through such a thorough preparation compared to bariatric surgery at all.
But also, the other thing that, although we are trying to get these patients ready for the surgery, throughout that process, although we do the population health management on the ACO side, if you look at it, what we do with the multidisciplinary approach here, we get the A1C, we get the hemoglobin, we get the TSH initially, right? So then we get the dietitians. And that happens in certain discipline, and the standard is pretty solid. So it provides a really good quality of care for that patient, even for the primary care. Foundation of the primary care is actually happening in the bariatric surgeons program. Yep. So I own a primary care office. So when I say this, I maybe some of my primary carers will be upset with me, but that cannot be done any better than the way that we are doing.
Absolutely.
Because all those things are being, because sometimes patient doesn't do X and we're like, no, you have to repeat it, because we don't let anything go to the next level if they don't complete it. If the even from the psych standpoint, from the EGDs, from the cardiology, sleep apnea, all those things are being addressed. So the safety standpoint is not the issue, but the type of the surgery, there's plenty of time to decide. But this, because I was just recently in Turkey, and when we talk about what we do, and some of our friends, they watch these events, and the understanding of the perception of the bariatric surgery is still limited.
Yes, very much so.
They're cutting stomach. Well, it's not cutting stomach. These patients, they are chronically ill, just like the patient with diabetes, just a patient with the heart disease. It's a disease. It's not like a choice. No one wants to be morbidly obese. This is not a choice. So we still want to, of course, put these type of procedure options, the education out there, but it's not the main decision that we need to make in the beginning. Now, Dr. Irgau, there are some less invasive procedures, as you mentioned. And one of the things that we did, I think we are the first one who operated the gastric balloon. And I think you are the first one in Delaware, or maybe in the East Coast, right? So
our practice, at least. Yeah, definitely.
So, well, you were on TV, actually. So we did this. Then this is not for the higher BMIs, but this is an option. Now, in my family, the wedding is coming up. And I was just thinking about this. There are some individuals who may benefit from it. So can you talk about the balloon a little bit?
Absolutely. So with the gastric balloon, essentially, it is really the least invasive procedure we have right now, because as I said, there is no cutting of the skin. It's all done endoscopically, right? The person takes a nap. We introduce a camera inside the stomach, and then we are able to deliver the balloon, which comes deflated, right? It's not inflated, otherwise it would not be able to go through the mouth or through the food pipe. It comes deflated, and then we position it, as you can see, inside the stomach, and then we inflate it. Okay, we fill it up, right? And then as the balloon fills up, it occupies a good amount of space in the stomach, and it does have some weight as well. That creates a sensation of fullness, right? The person will feel as if they've had 2-3 Thanksgiving dinners, right? They will really feel full. And the idea is, with them feeling full, they will be consuming less food, and that's exactly what happens. So with the balloon, clearly it's a reversible procedure, right? Because we have to take out the balloon after 6 months, and removal of the balloon by itself is the same procedure, which is the person takes a nap, and then we do endoscopy and remove the balloon, and it's a totally reversible procedure. The weight loss with the balloon, as I said, is anywhere between 20, 25 to 40, 45 pounds, depending on the person, their commitment, and so forth. Like all weight loss procedures, obviously there is going to be a range. In terms of the potential drawbacks, people may have some nausea or even some heartburn, particularly in the first week, and then we really have to watch them closely to make sure they don't become dehydrated. The vast majority of patients do very well. As a precaution, we put everybody that has a gastric balloon on an anti-acid medication to reduce the chances of irritation of the stomach or even ulcers in the stomach. And by far, the vast majority of people do very well. Probably the complication that people worry the most is maybe deflation of the balloon and then migration of the balloon down in the intestine that would potentially cause bowel blockage. That is a very rare event, but we do have ways to also protect the patient from that, because we put a special dye alongside the fluid that we use to inflate the balloon. And if there is a leakage from the balloon, that dye will be actually reabsorbed by the lining of the stomach and then excreted through the urine. And people will be seeing colored urine, green urine or blue urine. And if that happens, obviously they can let us know, and we can promptly remove the balloon before there is any concern for bowel blockage. But even that's not a very common procedure. It is currently a procedure that is not covered by insurance, and therefore people who have the balloon pay out of pocket for the gastric balloon.
And we have some financing options.
We do absolutely. The American Surgery Center does absolutely.
So, thank you again. So I'm going to just give a couple updates on our patient satisfactions. These are not industry standards, so I'm going to brag about them a little bit. So from American Surgery Center, we are at 99.4% patient satisfaction. These are our patients who would recommend us for family members or friends. In the last 12 months, there are 159 surveys came back, only one negative. That's 99.4%. And we thank all of our patients. And we also did mail out these individuals who had bariatric surgery among these. In case any of them would like to be participating in this event, we would like to welcome them. We are getting amazing responses from our patients, and we are very proud of what we get to see from them. As always, telemedicine is making the pandemic transition a lot easier, and we want to make sure that all of our patients are using. And I believe as CHRIAS, we are doing a lot better than many of the other practices, and we also thank our patients for their participation. There is a diabetes support group started by the UMACO under the Amy Wilkinson's leadership. This is coming up. You can follow our social media sites, and that's happening as we speak. Now, our events are pretty standard, so we are now back to our third round with the regular events. We'll be back on the weekly Bariatric Fridays after our 2 weeks break. So every Friday we'll be with you, and the second and fourth Tuesday with the CHRIAS weight loss seminars, which we go into the deeper clinical issues and answering some of those clinical questions. That's usually a little over an hour. If you want to actually know more about it, that's where you get that information. And our UMACO recent updates is at 12 noon every Friday right before this one. Today we had Sarah McBride. In case you weren't able to watch that, you could go back and watch that. Sarah McBride is our first transgender state senator in the United States. And she recently is supporting a bill for the paid FMLA. And I think that's important for our patients and for our employees. So we hosted her. And Wednesday Wellness webinar, this week actually we did one event, and that was for the home gardening. And Donna Gunkel and myself and Amy, we shared our home gardening experience and some pictures from that. So there are so much to see in our YouTube channels and social media, and hopefully everyone is able to benefit from these. Now, when we schedule these events, our goal is to be right on time. So now I had 2 events today. Now, Dr. Irgau, you were operating, and you have your own excuse, but I wasn't operating and I was late for the senator's event. So traffic was extremely bad with the beach traffic down to Roux-n-Y. So but we promised to be on time next week for the time that you spend with us. Thank you for being with us. And next week we'll be back with new topics and new guests. And until then, please stay safe. And Dr. Irgau, thank you for joining us.
Thank you, Kemal.